Hello, welcome back to pharmacology with Dr. Sokolow. So this is the last module on the autonomic nervous system, and this is the one on drugs that affect the adrenergic function. So first, we're going to talk about adrenergic agonists, which mean they mimic the effect of norepinephrine. So here you see we have the chemical structure of norepinephrine. You don't need to know the chemical structure of those molecules, but they are called catecholamines. So you see that they share those rings, and then this ethylamine, you see they have the same ethylamine function. So we'll see that you have some adrenergic agonists that are catecholamine, and then some are non-catecholamine, such as phenylephrine, ephedrine, and terbutamine. So what are the main function of the adrenergic receptor subtype? So again, this will bring you back to the beginning of this autonomic nervous system lectures, several series of video recording, and for you to remember the type of receptors, where they are located. And if you know where they're located, it's going to help you to know what is their function. So first of all, alpha-1 receptor, they are mainly located on the vasculature. So they're involved in vasoconstriction. Alpha-2 receptor, if you remember, they are located presynaptically, and mainly, their role is a negative feedback regulation. Dopamine, they are located on the kidney, on the renal blood vessel, and so they are involved in the dilation. When they are activated, dopamine will induce dilation of the renal blood vessel. Beta-1 receptor, remember, one heart, so beta-1 are on the heart in fight or flight reaction with the adrenergic nervous system. So increase the heart rate, increase the force of contraction, increase the velocity of conduction in the AV node. And then on the kidney, it's just increase the release of renin, which converts angiotensinogen into angiotensin, and this is a potent vasoconstrictor. Beta-2 on the lung, two lungs, and other, smooth muscle, but essentially for this quarter, we're going to talk about respiratory pharmacology. So the beta-2 receptor, once they are activated, they induce bronchodilation. And on other systems, such as the uterine system, they cause relaxation of the uterine muscle. They also induce the glycogenolysis, which is the production of glucose, because you want energy for that fight or flight reaction. So let's start with the drug that mimic the effect of epinephrine, norepinephrine. These are the catecholamine, and of course, epinephrine synthetic, which mimic the endogenous ligand, is used in code blue situations to resuscitate patients. So it's a potent cardiac stimulator. So because it binds to the beta-1 receptor and then induce, the heart rate. So it stimulates the heart rate. But because it's the natural ligand, it will also bind to the beta-2 receptor that are on the lung and induce bronchodilation. And then alpha is to do the constriction of the arteriole. So the EpiPen, that is used for emergency situation, people who has an anaphylactic shock reaction, where it's an important vasodilation caused by a large release of histamine. So if you give an EpiPen, it will just constrict all the vessel and prevent that vasodilation shock. In as I said, emergency situation, when it's used IV, is used for the treatment of cardiac arrest or acute hypotension, because again, it's a potent vasoconstrictor and it's a potent cardiostimulator. It can be used sub-Q or by as an inhaler for the treatment of asthma, but it's not really like the first choice for the treatment of asthma. And then it's also it's added to local anesthetic. And the reason why it's not driven to local anesthetic is just to produce vasoconstriction. And then if you use a local anesthetic, you want the effect to be localized by using that potent vasoconstriction. It will prolong the action of your local anesthetic where you want it, because it's not going to be like diffuse. And so that's why they are using it as an adjuvant to a local anesthetic. So that's epinephrine, which is, you know, acting on all type of receptors because that's the endogenous ligand. Now you have the beta selective. So you have some catecholamine that is going to mimic the effect of epinephrine on certain type of receptors. So isoproterenol is selective of beta 1 and beta 2 receptors. So beta 1, again, will stimulate the heart, and beta 2 bronchodilation. The butamine, this one is selective to the beta 1 receptor, which is good if you want, you know, just the cardiac effect. It will cause cardiac stimulation. So when are they used? They are used in acute bradyarrhythmia, so somebody with a very low heart rate, because it's a potent cardiac stimulant. That's why it's used. It can be used for cardiac heart failure, again, in emergency situation and heart block. Now, more catecholamines, norepinephrine. So it's, you know, a derivative of epinephrine, but that one, if you remember, only binds to the alpha and beta 1 receptor, not the beta 2. So it's more specific to the cardiovascular system. So on the alpha 1 receptors, it will cause vasoconstriction. On the beta 1, cardiostimulation. So these are used again in acute hypotensive state and cardiac arrest. Dopamine, if you remember in the synthesis of norepinephrine, dopamine is a precursor of norepinephrine. So it stimulates the beta 1 and alpha 1 and the dopaminergic receptor, of course. So if it's alpha 1, beta 1, again, more specific to the cardiovascular system, so cause cardiac stimulation, vasoconstriction. And because it stimulates the dopamine receptor, it will cause a vasodilation of the renal and mesenteric arteries. Again, clinical use, they are used IV. There are medications that you will see in an emergency situation, acute hypotension, acute bradyarrhythmia, cardiac heart failure, septic shock, and renal failure, because this one has an effect on the renal arteries. Now you have the non-catecholamine drugs. So they're still sympathomimetic, so they mimic the effect of norepinephrine. It's because, but they are different from their structure. So if you remember the chemical structure I showed you, you know, all the catecholamine have the same ring and the same ethanolamine function. This one are different. So the first one are the beta 2 selective agonist agent. So beta 2 lungs, and so lungs are used to cause bronchodilation, so they will be used for the treatment of asthma, like terbutaline and albuterol. And then terbutaline, you may see it in emergency room for women who come with preterm labor. Because remember, there are some beta receptor on the uterus muscle. And so it is used off-label at high dose in, you know, emergency room to prevent, you know, woman who's going in preterm labor to prevent labor, basically. So don't be surprised if you see a drug that is used for asthma to be used for this particular indication, even though it's not. Then you have the beta-3 selective agonist. This one, so the beta-3 receptors are also located on the smooth muscle cell of the bladder. And mirabegron is a beta-3 selective agonist, which is used for the treatment of overactive bladder because it relaxes the detrusor muscle. Here come my little balloon again. So if you relax the muscle that squeezes the bladder, you just prevent, or you can just treat actually overactive bladder. And then you have alpha-1 selective agonists, such as phenylephrine. So this one is very common over the counter. It's actually a nasal decongestant. And so those drugs, right now, it's a lot of name to remember. And again, what you have to know is like which type of receptor they are binding to. Is it, alpha-1, beta-1, beta receptor, or is it more for the cholinergic system? For this class, for this chapter in particular, because we will see in more detail drugs for the respiratory pharmacology, drug for asthma, drug for allergies. So when we come to that lecture, you will know in more detail how, adverse effect indication of phenylephrine albuterol. But for right now, what I want you to focus is to know if it's an adrenergic agent, an anti-adrenergic agent, is it cholinergic effect, or is it an adrenergic effect, and which type of receptor they are acting on? Are they agonists or antagonists? So when you study, that's really how you have to study it. And then alpha-2 selective agonist, it's clonidine. So this one, it's an agonist of the alpha-2 receptor. But if you remember, the alpha-2 receptor, they are presynaptic, and when they're activated, they prevent the release of more norepinephrine. So basically, they kind of act as an antagonist. They are involved with the negative feedback loop. So clonidine, even though it's an agonist, acts as an antagonist, and it's used for the treatment of hypertension, like refractory hypertension. Also used for migraine and opioid withdrawal symptoms. For those indications, we don't exactly know the mechanism of action, but we know how it works for the treatment of hypertension. It's because it prevents the release of norepinephrine and therefore will reduce the blood pressure. So that was for the agonist of the adrenergic system. Now we're talking about the antagonist. And so those antagonists, you have antagonists that will ask on the cardiovascular system if they bind to the alpha-1 or beta-1 receptors. And then you have those who worked on the respiratory if they bind onto the beta-2 receptor. So alpha-1 antagonists, alpha-1 mainly localized on the vessels. So treatment of hypertension, prazosin, terazosin, and treatment of BPH, benign prostatic hypertrophy. So that's tamsulosin. So here, if you see, I underline the ending. They have the same ending. So if you know one of those endings, you can say, oh yeah, maybe these are alpha-1 selective antagonists. And then again, we'll see those in more detail when we get to the lecture on hypertension. So tamsulosin, as you see, it's more selective for the prostate smooth muscle versus the other, vascular smooth muscle. Now, if you have a patient who has hypertension and BPH, that they are the less selective agent will be better because they will act on both. And then other agent that can be used for BPH is finasteride or Proscar, and that one acts on a different mechanism, which block the 5-alpha reductase, which is block the conversion of testosterone into dihydrotestosterone. And dihydrotestosterone is the active form of testosterone. So if you reduce the amount of testosterone, then you can reduce the symptom of BPH if it's induced by an excess of hormone. And then I also put a box here that finasteride is also approved for the treatment of androgenic alopecia, which means males who are losing their hair. Now this one, you see, I have a lot of thing on it and some mnemonic. This is a slide that has a lot of information, and then again, it seems a lot right now, but I can reassure you when we'll see the cardiovascular lecture, if you really, understand this one, you'll have, it will be so much easier when we get into the cardiovascular pharmacology. So these are the drugs that are adrenergic receptor beta antagonists, but we call them beta blockers. And I'm sure you already heard the term beta blockers, and you know that beta blockers have a lot of indication for the cardiovascular system. You have, of course, different type of beta blockers. And the older one were the one that were non-selective. That means could bind to both beta 1 and beta 2. But beta 2, if you block the receptor of your lung, is going to cause a bronchoconstriction. So a patient who has hypertension and is on a beta blocker and has asthma, that can trigger a bronchospasm. So that's not going to be good for them. And so that's why now you have more selective drugs that have less effect on the bronchi and more effect on the heart and the vasculature. So older drugs bind to both beta 1, beta 2, and that's propranolol. You also have drugs that are used topically for the treatment of glaucoma, and this is timolol. Then you have the selective beta 1, they are newer. And here I put ATBM, so it's atenolol, bisoprolol, and metoprolol. So that's why if you want to remember which one, so for the beta 1, ATBM, atenolol, bisoprolol, metoprolol. Then you have the partial agonist. So partial agonist, again, you remember it has some intrinsic activity, so act as an agonist, but also block the receptor as an antagonist. That's why I put this ACE here, because this guy is the ACE butalol. It can do both. Beta blocker, but with intrinsic activity. So it depresses the heart rate, but less than the other beta blocker because of that intrinsic activity. So ACE butalol. And then lastly, you have the non-selective beta blockade with alpha blockade. So this one will block beta 1, beta 2, and also alpha 1. So it's carvedilol and labetalol. So these are my favorite flowers. They are calla flowers. So calla for carvedilol and labetalol. And this one lower the blood pressure, but can also cause postural hypotension because of the alpha blockade. So when you have an important vasodilation and you change position, you stand up, you can have, you can be dizzy. It's because of that postural. It's called postural hypotension, and it's because of that large vasodilation, which will be caused by the alpha blockade. So I hope this mnemonic will help you remembering the different type of beta blocker and their use. Clinical use. So as I said, those that are acting on the cardiovascular system are used for hypertension, angina pectoris, MI, cardiac heart failure, antiarrhythmia, migraine, and glaucoma. And this concludes the lecture on autonomic nervous system. I know it seems a lot, but it's going to really help you understand the respiratory and cardiovascular pharmacology that we will see in more detail after the midterm. So the time you're going to spend on this lecture is going to save you time later on. And I think it's very important to understand the cholinergic and the adrenergic function. So thank you so much for watching, and I will see you soon.